Hi, everyone. Welcome to our Monty Hart lecture series. It's a great pleasure to have today Dr. Miguel Caínzos-Achirica, who will be speaking about the emerging roles of CAC score in therapy allocation in primary prevention. Dr. Caínzos-Achirica is the Section Chief of Preventive Cardiology and Director of Research at the Hospital del Mar in Barcelona, and he's also an adjunct faculty at the Cicarone Center from Johns Hopkins University. Dr. Caínzos is a preventive cardiologist and cardiovascular epidemiologist trained in Barcelona and Johns Hopkins in Baltimore. His research focuses on two complementary approaches to the prevention of cardiovascular disease. One, interventions at the population level with a special focus in identification of vulnerable populations, minorities, and other groups at increased risk of cardiovascular disease, and also interventions at the individual level using cardiac imaging and other novel biomarkers to inform a most precise cardiovascular risk management. So I'm very excited for your talk, and I got, even before, a lot of messages on other people how excited they were to see you. You've been defined by some of your mentors as a Lionel Messi of preventive cardiology. So we're happy to have you here. Thank you.
Well, thank you so much for the kind introduction, Leandro, and thank you to Montefiore for this invitation. I'm definitely looking forward to this discussion. So let me just minimize the video part. And also thank you to my mentors for comparing me with Messi. I think that's quite an hyperbole, but I will try to do my best. So I'm going to be talking today about emerging roles of CAC, the CAC score in therapy allocation and primary prevention. And yes, my name is Miguel Caínzos, and I work in Barcelona in the Hospital Mar, the one that is in the picture on the left. So these are my disclosures. Let's start here. So why are we talking about CAC, and why are we talking about personalized allocation of therapies in primary prevention? And the reason is that the tools that we have nowadays to allocate those interventions are pretty suboptimal, to say the least. And I'm going to give you an example with the tool that we have here in Europe, which is the SCORE2 charts. And specifically, I'm showing the ones for a low-risk country like Spain. These kind of tools, the clinical risk scores, they are strongly influenced by age, especially, and also by sex. And this is a problem when it comes to therapy allocation and primary prevention. Let's think about this woman A. She's a 64-year-old woman with no cardiovascular risk factors, with a normal blood pressure. She's a non-smoker. And according to SCORE2 in a low-risk country, she has a 4% risk at 10 years of having an ASCVD event. What about this other woman B? She's also 64 years old, which is very important for SCORE2, same age as the other woman. But this woman, she experienced preeclampsia in one of the pregnancies that she had. She also had gestational diabetes, and she had one abortion. She has an HbA1c of 6.3%, which is pre-diabetes and close to diabetes, BMI of 27.6. She has psoriasis, which is a chronic inflammatory condition that is strongly associated with an increased risk of ASCVD, and a systolic blood pressure that is on the normal high range, according to European definitions, and even slightly hypertension for the US definition. But this woman, according to SCORE2, she also has a 4% risk of an ASCVD event at 10 years, the same like woman A, even though obviously it's obvious for us as clinicians that these two women are pretty different from each other. What happens next year? Now, both of them, they are 65 years old. So now woman B, she has become a candidate for starting therapy in primary prevention according to SCORE2 and the ESC guidelines. But also woman A, despite the fact that she has no traditional risk factor at all, other than her age, chronological age of 65 years. So this is the kind of situation that we deal with a lot when we're trying to stratify risk in primary prevention using traditional tools like the pool cohort equations in the US or SCORE2 charts in Europe. More examples of this situation. So in terms of chronological age, as I mentioned, almost every woman in Europe, including in low-risk countries, and even if they are non-smokers, are going to be considered, if they are 65 years of age or above, they're going to be considered potential candidates for statins in primary prevention. And of course, for men, this is even a greater deal. We're talking about almost every man without risk factors, 55 years of age or older, is going to be considered a potential candidate for statins in primary prevention. And not to mention smokers. For smokers, this applies to almost everybody, especially for men in primary prevention in European countries. And we have similar issues with the pool cohort equations in the US, especially after the 2013 guidelines, as you are perfectly aware. But what is the context? So do we have an actual reason? Is there really a pushing need from an epidemiological standpoint, or for other reasons, to be so willing to give statins to so many patients or to so many apparently healthy people in primary prevention? What are the trends in recent years in terms of ASCVD, in terms of CHD, and in terms of mortality? And the truth is that the trends are pretty good and pretty reassuring. This is data presented in the AHA conference a few years ago. This was AHA 21, presented by Dr. Joy Jones, who was the president back then. And he showed how CVD death in the US has fallen in a dramatic manner in the last 50 years. We're talking about a 70% fall reduction in CVD mortality. And this is very similar to what we see in other Western countries, including Europe and including Spain. What about incidence? The incidence of CHD and ASCVD has also gone down very significantly in the last few decades. So definitely very reassuring trends, and trends that wouldn't support the need to be so aggressive using preventive therapies in a large portion of the population in primary prevention. Are there other arguments to be as precise as possible, as personalized as possible, be using interventions in primary prevention? Of course, there's a lot of reasons, not only these trends that I just showed you, but also other reasons, like, for example, the concept that one size does not fit all. Not all therapies are good for everybody, but we really want to identify the right target for the right therapy. And the concept of precision medicine makes a lot of sense, not only in cancer, as it was initially presented, and this is, for example, President Obama back in 2015 discussing this concept of using the right dose of medicine in the right patient in the context of cancer treatment. But this is a concept that also makes a lot of sense in the treatment and the prevention of ASCVD in our patients. When we think about healthcare expenditure, we know that costs and expenditure are going up. In most countries, this is on the left data for the US, on the right data for Spain. And in both countries, you can see how expenditure is going up. And we have a strong reason to be as precise as possible using interventions in our patients, and especially when we're trying to prevent something from happening. And we definitely want to focus on those who are at higher risk of having those events. Even from an ethics standpoint, if you have recently checked the Code of Medical Ethics, there's a section specifically talking about allocation of limited healthcare resources, and the code emphasizes the notion of, in a context of limited healthcare resources, trying to prioritize interventions in those who are most likely to derive the largest benefit from the intervention. So there's a lot of reasons to be precise, and when it comes to precision and ASCVD prevention, the CAC score can be a really useful tool for this purpose. And I'm going to tell you why. The CAC score is a marker calcified plaque, coronary calcified plaque, and this is strongly associated, the burden of calcified plaque in your coronary arteries is strongly associated with the total burden of plaque in the coronary arteries, both calcified and non-calcified, as demonstrated by John Rumberger and others a few decades ago. And the burden of coronary plaque in your coronary arteries is strongly associated with the risk of having a CHD and an ASCVD event during follow-up, independent of traditional risk factors. So this is the reason why this number, the CAC score, and this information about your calcified plaque in your coronary arteries is going to be so informative in terms of your risk of having a CHD event and an ASCVD event during follow-up. And we like to call it the central illustration of ASCVD risk. We're using this term, the central illustration, coming from JACC and other journals. And we think that this is actually the case here because this number, this CAC score, is going to give you a lot of information about your exposure, your lifetime exposure to so many things during your lifetime. It's going to give you information about exposure to risk factors, traditional risk factors like changes in blood pressure over time, cholesterol levels, weight changes, but also exposure to stress, pollution, your adherence to recommendations like lifestyle recommendations. All of these are things that are really hard to measure in the clinic. And many times clinical risk scores are going to fail to capture those pieces of information. But also, and perhaps most importantly, this number is also going to give you information about something that is even harder to measure, which is your individual susceptibility and your resilience to atherosclerosis, which is a consequence of processes like genetic factors, epigenetic factors, SDOH, access to care, adherence, and many others. So the combination of all these features defines the burden of plaque in your coronary arteries, and the CAC score is going to give you a summary measure specifically of that information. So it's going to capture in a single number a lot of information about all these processes. The higher the CAC score, the higher the risk, and this is something that has been demonstrated in a number of papers. This is, for example, a very nice study by the Mike Laha group in the Coronary Center, showing that the higher the CAC score, the higher the rates of events during follow-up, especially when you have a CAC score that is above 100, and even more if the CAC score is above 300. That's like the magic number when you try to identify those event rates that are close to secondary prevention populations. When you have a CAC score that is greater than 300, and even more if it's close to 1,000, then you really want to treat those patients very aggressively with all the therapies that you have available to try to reduce ASCVD risk as much as possible in your patient. And we're going to talk about some of those interventions and therapies in a few slides. For all these reasons, the AHA ACC guidelines, they endorse the use of CAC for the allocation of therapies in primary prevention. And this was endorsed with a 2A recommendation in 2018 and the 2019 guidelines for treatment of blood cholesterol and primary prevention of ASCVD in clinical practice. And specifically, what the guidelines recommend is that you should be using CAC to inform those decisions, especially statin allocation, in patients in whom the risk management is uncertain after a risk discussion and after using traditional risk scores like the pool cohort equations. In those individuals in the intermediate risk realm, CAC is going to be the best tool to further stratify your patients and make a final decision about whether they should be, for the rest of their life, treated with a statin or other therapies in primary prevention. But of course, and this always comes up, should we be using CAC to inform decisions in all patients in primary prevention? And of course not. You want to use it in the right patient. And we like to compare this with this COVID-19 analogy that we came up with during the pandemic. When the pandemic started, or at least when we started to have some vaccines for our patients, we remember that there were patients who were so interested in getting the vaccine that they would start asking about second dose, a third dose. And we like to think about this fifth dose or patient, this patient who is always thinking about how to minimize risks, how to maximize protection. In the context of ASCVD risk reduction and prevention, we would think of this patient as the patient who is likely to buy statins over the counter. This patient prioritizes reducing risk, minimizing risks, and this patient most likely doesn't need a CAC scan at all, because this patient, if there's any indication to take a statin, this patient is going to commit to the statin, so the CAC scan is not going to make any difference. Thinking about this COVID-19 analogy, we can also think about the other extreme of the spectrum, which was the anti-vaxxer, this patient who wouldn't get the vaccine despite overwhelming information about mortality with COVID and about the complications of the infection, but still they wouldn't want to take the therapy, or in this case, the vaccine. In the ASCVD risk reduction realm, this patient would be the kind of patient who wouldn't take the statin regardless of whatever we tell them, regardless of the risk score that we use or the tool that we use to inform them, even though in some cases, with information about coronary plaque burden, they might change their mind. But in most of these patients, we're not going to want to do a CAC scan either, because it's not going to change the way they're going to handle or manage the risk. Luckily, most of our patients, they are not they're not in any of these extremes, but actually they are patients who acknowledge uncertainty, patients who understand these decisions as complex decisions, and we like to call them the shared decision makers, because these are patients who are going to listen to the physician, they are going to ask questions, they're going to integrate a lot of information, and they're going to want to make that the shared decision in terms of statin therapy or other interventions in primary prevention. This is the kind of patient that we tell them that they have a 6% risk at 10 years of having an ASCVD event. They're going to emphasize the fact that also, or raise at least the fact that this means that they have a 94% odds or probability of not having an event at 10 years, which is definitely true. And these patients understand that this is a complex decision, and they're going to want to integrate a lot of pieces of information. They want to know the data. They want to understand the efficacy of the intervention that is being proposed. They want to know the side effects of the potential intervention. They want to know the cost and incorporate this into decision-making. They want to understand whether the intervention is actually relevant to them specifically and not only based on epidemiological data. And they want to understand the value in terms of absolute risk reduction. For the last two items, CAC can be really useful, because it's going to give you a lot of information about whether the potential absolute risk reduction is going to be large or not in your specific patient. And it can also be very helpful motivating the patient, because the moment they see on the screen and the burden of plaque that they have in the coronary arteries, this is going to many times change their mind or make them more motivated to adhere to lifestyle recommendations and to therapies for the prevention of ASCVD events. This is going to be a discussion that is going to be particularly important when the therapy that we're talking about means significant cost to the patient or has the risk of potential side effects. So this is the kind of the concept that we try to summarize in this figure in the BMJ review with Karam Naser a few years ago, talking about the fact that CAC can be useful in those intermediate risk patients who are open and willing to incorporate additional information to make a final decision. If the patient already has made a final decision based on the clinical information, like the pool cohort equations, then it doesn't make any sense to do a CT scan in this situation. So what are we going to be using the CAC scan for? The basic use and the guideline-endorsed use of CAC nowadays is for the location of statin therapy in primary prevention. And this recommendation, as I mentioned before, is a two-way recommendation and is based on a wealth of publications in the space, many of them high impact, and many of them contributed by the Chiccaroni group at Hopkins and other groups working with MESA and other cohorts. And these are just a couple of examples. We don't have time to go through all of them, but on the left, we have this New England Journal paper in 2008 by Detrano and colleagues. On the right, this paper by Matt Budoff and colleagues in the European Heart Journal in 2018. In both of them, as you can see, the higher the CAC scan, the CAC score, the higher the rates of events at 5 years, 10 years, and even 12 years. And if you have a CAC score of 0, as you can see in all of these figures, the rates of events during follow-up are going to be pretty low, close to 0 at 5 years, and pretty low also at 10 and 12 years. And perhaps one of the most impactful papers in this space was this publication by Karam and colleagues in 2015 in JAC, where they showed that using the pool cohort equations, you have an estimated risk that ranges from 7.5 to 20%. There's a lot of people there who have a CAC scores of 0. Actually, close to 50% of them, they have a CAC score of 0. And among them, the event rates at 10 years of follow-up are pretty low, definitely below the 7.5 threshold for statin therapy allocation. And this is the paper that pushed forward the concept of the power of 0, and that impacted the guidelines, making the guideline authors suggest that in this range of 7.5 to 10% estimated risk, it does make sense to use the CAC scan to make a final decision about whether you should be or not on a statin. But what about other therapies? So statins, of course, it does make a lot of sense to use CAC to decide the allocation of these therapies. But what about other potential interventions? And nowadays, we have a lot of interventions in primary prevention that can be used to reduce risk in our patients, not only statins, but many others. And CAC can have a pretty relevant role in the allocation of these interventions as well. And let me go through some examples. Of course, we do have healthy lifestyles in primary prevention. This is something that we would recommend to almost all of our patients because they are good for all. And you wouldn't want to use a CAC scan to recommend a healthy lifestyle, even though, of course, in those patients who learn that they have plaque in their coronary arteries, they might be more motivated to adhere to those recommendations after having that information. But in general, you wouldn't want to use a CAC scan for this purpose. Statins, we already talked about that. It does make a lot of sense to use CAC, specifically in those patients who really don't have, we're uncertain about what to do about using or not a statin in the long term. But it could be argued that statins nowadays, they are safe, they have rare side effects. Nowadays, most of them are available in genetic forms at low cost, and there's a strong long-term benefit in most groups. So it could be argued that if the patient is motivated to commit to statin therapy in the long term, why do a CAC scan at all if the patient is motivated? Obviously, it's going to be useful if the patient has questions about whether they should be or not in a statin. But in patients who are highly motivated, maybe it's just a matter of letting them take the statin and benefit from this therapy, especially in the long term. But for other therapies in primary prevention, therapies that involve potential risks of side effects, like aspirin, or that have significant cost to the patient and the system, like PCSK9 inhibitors, GLP-1 arrays, and other therapies, here's where I and others feel that CAC can really make a big difference in forming the allocation, a most personalized allocation of these interventions in primary prevention, trying to be as cost-effective and as relevant to patients as possible. And this is the concept that we tried to summarize in this figure with Karam a couple of years ago in our review in this space. And basically what we suggested was that almost every decision in primary prevention involving ASCP risk reduction interventions could be informed by the CAC score or the CAC burden of the patient, especially for those therapies, as I mentioned, that involve a higher cost or potential for side effects in these patients. And in this situation, we're going to be using CAC for a dual purpose. In those individuals who have a CAC score of 0, then you want to consider withholding or delaying the intervention because the absolute risk reduction is going to be very small in that patient, and most likely the allocation of a costly therapy is not going to be cost effective in that situation. Whereas on the other hand, if the patient has a high CAC score, above 100 or even higher, then it does make sense to consider using as many risk reduction interventions as possible, because you're going to be treating a patient who has high rates of events or a high risk of having an event in the next 10 years, and the absolute risk reduction is going to be significant. So when we think about other therapies, not only statins in primary prevention, of course, the first one that comes to mind is aspirin. And this is a pretty controversial topic, and one that I very much enjoy discussing. Aspirin is currently endorsed in the American guidelines with a 2BA recommendation, and similar in the European guidelines. So this paper that we did in 2020 in Circulation is really not about whether you should be using or not aspirin in your patients who are asymptomatic, but actually it's about whether, if you're thinking about using aspirin in your patients who are asymptomatic, what is the best tool to inform that decision? Should you be using should you be using the full cohort equations, or do you want to use something else, like, for example, the CAC scan? And this is what we showed. What we see is that the full cohort equations, they really have a really hard time trying to differentiate the patients who should be versus those who should not be on aspirin in primary prevention. The reason for this is that the full cohort equations, they use factors that are both strongly associated with the risk of bleeding and with the risk of ASCVD events. So you can see how on the right, even if you have a ASCVD risk estimated that is about 20%, the number needed to treat, which is the vertical bars, and the number needed to harm, which is the horizontal line, are going to be pretty close to each other. And on the other groups, actually, you're going to cause net harm if you use aspirin in primary prevention. So you don't want to use the full cohort equations to inform this decision. What about the CAC score? Well, if you have a CAC score of 0, you definitely want to avoid using aspirin in primary prevention. Why is that? Well, in all groups, including on the right, the one with an estimated risk of about 20%, the number needed to treat with aspirin to prevent one ASCVD event is going to be higher than the number needed to harm. So you're going to cause net harm with aspirin in this situation, even in the supposed to be higher risk individuals. And keep in mind that this analysis was conducted in people who were at low risk of bleeding. This was a subset of participants from MESA. Let's hide this. Okay. So what about if you have a high CAC score? If you have a high CAC score, especially, let's check the chat in case there's something. No. Okay. This question, Q&A, prevent calculator. Okay. Just hide the chat again. Okay. So what happens if you have a high CAC score above 100 and especially above 400? Then the number needed to treat in all groups becomes way lower than the number needed to harm. And this is very important in all groups, but particularly different in those individuals who are younger. And we see this on the left because the people who get estimated risk below 5% are usually the younger individuals. And in this situation, you can see how the number needed to treat is way lower than the number needed to harm. And this is very consistent with the USPSTF guidelines, which recommended the potential consideration of aspirin in the highest risk individuals who are younger than 60 at low risk of bleeding, but do have a very high risk of ASCVD events. So in those individuals who are 40-something, 50-ish, and for whatever reason, they have a lot of plaque in their coronary arteries, and maybe for genetic reasons, high Lp(a) or other factors, and they have a low risk of bleeding, maybe in those individuals, and besides, of course, progressive LDL cholesterol reduction, you may want to consider using aspirin for further risk reduction. Those analyses were done in MESA, but subsequently they were confirmed in a different cohort in Dallas Heart Study, which is a younger cohort. The authors, they use a different methodology, a different approach, but they found exactly the same. In low risk, in individuals at low risk of bleeding, the CAC scan is going to be really useful to identify people who are not at high risk of bleeding, but they are at high risk of ASCVD events. And the result of potential use of aspirin in this situation is going to be net benefit. What about other therapies? So we talked about statins and aspirin, but nowadays we also have, for example, ASCVD risk reduction therapies in people with diabetes. And we know that in diabetes also, CAC is really useful stratifying risk and primary prevention. What happens with those therapies, like, for example, dulaglutide in the REWIND trial that showed a 10% risk reduction of ASCVD events also in the primary prevention subcohort of the trial? Well, we know that some of these therapies are used nowadays in primary prevention for risk reduction in individuals with diabetes. And there's guidelines in the US that recommend the use of GLP-1 for this purpose in many patients with diabetes, usually based on the number of traditional risk factors, age, and other considerations. And there are some people who are not recommended for GLP-1 therapy in this context. What we did with this analysis that I'm showing you right now, we combined several cohorts, MESA, Heinz-Nexdorf, and other cohorts in the US, and we assessed First of all, the prevalence of CAC 0, which is the light blue bar, in these groups, in people recommended for GLP-1 RAs and people not recommended for GLP-1 RAs. And you can see how among people who were recommended this therapy, one third of them, they had a CAC score of 0. And among people who were not recommended for GLP-1 RA for risk reduction therapy, we saw that 13% of them, they had very high CAC scores above 100. What happens with event rates in these individuals? On the left, we have the 5-year cumulative incidence of MACE by CAC strata in these individuals overall with diabetes, those recommended for GLP-1 RAs and those not recommended for GLP-1 RAs. And on the right, we have exactly the same groups, 10-year cumulative incidence of MACE. Among individuals who were recommended for GLP-1 RAs, you see that people with a CAC score of 0, they had pretty low event rates compared to the overall group, and especially compared to those with higher CAC scores. And especially among those not recommended for GLP-1 RAs, those with a CAC score greater than 100, they had pretty high event rates, very similar to those who were recommended for GLP-1 RAs. So again, we are showing that CAC can be really useful, both personalized allocation of therapies in those who are recommended, at least based on the number of traditional risk factors for a specific therapy, in this case, for GLP-1 RAs when used for ASCVD risk reduction. And on the right, also identified potential additional candidates with diabetes for this kind of therapy. When we do the analysis based on the number needed to treat, which is just a transformation of the absolute risk reduction seen in the other slide, we see exactly the same. But especially what we see is that among people who are recommended for GLP-1 RAs in primary prevention, if you have a CAC score of 0, the number needed to treat becomes really high for the prevention of ASCVD events. Of course, you may want to still want to use this kind of therapy for things like weight loss and other indications. But if the main purpose of this allocation is for the reduction of ASCVD events, then the number needed to treat is going to be pretty high for a therapy that usually is pretty expensive. On the other hand, if you're thinking about reducing ASCVD events, you really want to check those CAC scans and those CAC scores in your patients, because many times you're going to find additional candidates who might derive benefit, and the number needed to treat is not so prohibitive. Other scenario, what about therapies for the reduction of ASCVD risk in people with hypertriglyceridemia? Again, exactly the same scenario as the one that we talked before for diabetes. In this case, what we did, we combined data from 4 cohorts, MESA, TALASAR study, CARDIA, and Heinz-Nixdorf, and we combined data for individual level data for 2,400 people with hypertriglyceridemia. And now we're thinking about therapies like icosapentathil in people with hypertriglyceridemia for ASCVD risk reduction. Among people who are considered eligible based on the product label for IP in primary prevention, we see that 25% of them, they have a CAC score of 0. And among those who are considered not eligible based on the product label, we see that one-fifth of them, they do have very high CAC scores. And this translates into very high event rates. As you can see here on the left, among people who are not eligible, if they have a CAC score greater than 100, they do have really high event rates. And most likely these individuals, they will benefit not only from LDL reduction, but also from treatments like icosapentathil. On the left, among people who are IP eligible based on the product label, if you have a CAC score of 0, the event rates are lower than the overall rates for this group, even though they are not so low, they are above 7.5%. Still, it's important to keep in mind that these cohorts are from the early 2000s, so most of them, they didn't get, or they were not being treated with statins as aggressively as they would be treated nowadays. So most likely those event rates would be a bit lower in the current context in 2024. On the right, you have the number needed to treat analysis, which again shows that the number needed to treat for people who have hypertriglyceridemia and very high CAC scores, the number needed to treat with icosapentathil, assuming that the risk reduction shown in the major trials will remain the same, would be pretty low compared to what we will see in people with a CAC score of 0. And there's a lot of papers and a lot of literature in this space for many other interventions. We have discussed a few of them: statins. We have talked about low-dose aspirin, ASCVD risk reduction in people with diabetes. We have talked about risk reduction in people with hypertriglyceridemia. But there have been other important papers in this space. A couple of them led by Bill McEvoy. As you know, he used to be in Hopkins. Now he's back in Ireland. First of them discussing the potential use of CAC to inform the allocation or the blood pressure goals in people with hypertension. That was a circulation in 2017. And he also assessed the potential role of CAC, guiding the allocation of low-dose rivaroxaban in people who are at highest risk of ASCVD in primary prevention. What about risk stratification in people with FH or with LDL cholesterol above 190? There's a lot of work also in this space, led by the group from Raul Santos in Brazil, also Karam Naser and Seth Martin Hopkins. And in all of them, we have shown, and they have shown, that CAC can be also really useful stratifying risk in these populations. And this is a recent paper also in this space where we tested the potential role of CAC guiding the allocation of PCSK9 inhibitors in people with different potential indications, whether you use or you consider people who are, you consider the candidacy for PCSK9 inhibitors based on the levels of LDL cholesterol alone, or whether you combine this with other criteria or other considerations. In all of them, if you have a CAC score of 0, the event rates are going to be pretty low, especially in people who only have high levels of LDL cholesterol. And in those individuals, actually, the prevalence of CAC the CAC 0 is pretty low. Pretty high. We're talking about 35% of them, they do have CAC scores of 0. And the event rates are as low as 2.6 at 10 years of follow-up. We're talking about ASCVD events. Okay, so we have a lot of situations where CAC can be useful, guiding the allocation of interventions, many interventions in primary prevention. But how do we find those patients? How do we identify those candidates, those patients with very high CAC scores in clinical practice? And here comes the importance of incidental findings of high CAC scores in our patients. And the reason for this is that even though the guidelines nowadays, they do recommend treating very aggressively and considering very high risk, those individuals who do have evidence on imaging of having a very high CAC score, and this is, for example, from the ESC guidelines, and also the US guidelines are increasingly emphasizing the importance of subclinical ASCVD. The problem is that nowadays, in many environments, especially in Europe, we don't have that much access to CAC scanning because public systems, they tend not to cover this test. And also in the US, many insurance companies, they don't cover this test either. So in many systems, we are not getting those CAC scans done, and many of our patients in primary prevention, we don't have that information. Also, there's currently no evidence to go to the general population and scan people just for screening purposes and to identify those with very high CAC scores. So how should we find those patients? Well, the good news in this context is that nowadays, hospitals have become huge hubs of CT images done for many reasons, and this includes chest CT images done for a number of clinical indications. And this gives us a chance for an opportunistic detection of a lot of patients with high CAC scores in those CT scans. The Stanford group is doing a lot of interesting work in this space, and they have shown that those incidental findings in chest CTs done for other purposes are strongly associated with ASCVD events during follow-up. And these are analyses adjusting for traditional risk factors. The associations are pretty strong, despite the fact that these chest CT scans were not done specifically for CAC assessment, but this can be assessed using a number of algorithms, including AI algorithms that they have validated in other groups as well. But most importantly, those findings, they have clinical implications because they change the way we manage those patients. And they demonstrated this in the Notify-1 trial, where they showed that when people have this information about the burden of CAC in their coronary arteries, and we give this information to clinicians and patients, the use of preventive therapies, particularly statins, increases dramatically. And they showed that this number went from 7% in the people who didn't have this information. This was statin use in those who did have information about traditional risk factors and other features, but they didn't know their CAC scan or their CAC score. This went from 7% to 51% at 6 months in the group who did have information about their CAC score. So definitely, it's not only that this finding is relevant and is associated with ASCVD events, but actually the most important thing is that it can change the way we manage these patients in primary prevention. So definitely something worth finding in our patients and worth checking in the CAC scans that are done in clinical practice in our systems. And this is what we're doing here in Barcelona, in the Hospital del Mar. So we have established the strategy. This started a few months ago. This was just more or less 12 months ago. And we call it this is a strategy, a hospital-wide strategy. And we're seeing these patients in a dedicated clinic that we call the primary and a half prevention clinic or 1.5 prevention clinic. And we see all these kind of patients, not only patients with high CAC scores, but also patients with other findings, relevant findings of subclinical disease based on coronary CTs, coronary angiographies, carotid ultrasound, and others. But I wanted to focus here specifically on people with chest CT showing coronary calcifications, because definitely these patients, we are seeing them in the clinic, following them for 12 months and making sure that they get the best treatment for the risk of ASCVD events. We make sure that we communicate this information to our patients, that seeing is believing in the field of ASCVD prevention. So we show them on the screen what we see in their scans. And this is an example of an actual patient, one of the very first patients that we saw a year ago in the clinic, who has, as you can see, a lot of calcium, the left anterior descending, also in the ascending aorta, descending aorta. And we use this information because we know that visualization of atherosclerosis is associated with higher rates of prescription of optimal medical therapy by physicians, and also enhanced adherence by patients, which is an important unmet need in primary prevention. So we use this information, first of all, to identify the patients who should be on intensive therapy like statins and other interventions. And second, we use this information to motivate the patient to remain on those interventions in the long term. This is the kind of materials that we use so that they understand what they are experiencing, what they have in their coronary arteries, despite the fact that they don't have any symptoms yet. But we still try to convince them that this is an important process that they need to take care of, and that they need to implement the interventions that we discuss in the clinic and in the structured follow-up for those 12 months. We're doing a study nowadays funded by the Hospital del Mar and Hospital del Mar Research Institute, and also we're lucky to have support from Novo Nordisk for this study. This is called the USET study. We're running the pilot right now, and we're expecting to have results very soon. And Dr. Carolina Papaliteri, she is leading this study in our center. Okay, and finally, I wanted to also talk about the potential use of CAC for efficient participant enrollment in clinical trials in primary prevention. This is also an important field because there's still a lot of research and development of new molecules in the field of primary prevention. And CAC can also be really useful in identifying the potential candidates for those therapies, and also for the design of the trials that we are going to be conducting in the next few years in primary ASCVD prevention. This is an idea that came up a few years ago. This was an idea presented by Marcio Bittencourt, Ron Blankstein, and Karam Naser in the European Journal of Preventive Cardiology. This was a letter that they presented, published in 2015. And subsequently, we tested this approach. We tested using CAC for an efficient enrollment of participants in primary prevention trials. This was a paper that we published in JACC Imaging a few years ago. What we did, we compared CAC versus other strategies for the identification of potential participants in primary prevention trials. And what we showed is that definitely CAC, especially if you have a very high CAC score, is the best way to go to make your trial smaller in terms of the number of participants, enrich it with a higher risk patient population with more events, and make the trial more feasible, less expensive, and easier to conduct for industry and for the sponsors, and definitely a way to facilitate the development and generation of knowledge in primary prevention. Subsequently, we thought further about this paradigm, and we realized that obviously getting everybody a CAC scan from scratch in this enrollment process of a clinical trial would be would be a quite intensive, long, and logistically complex process. And we realized that instead of scanning people from zero, why not use the information that is already waiting for us in those chest CTs and those CAC databases that are already available in many healthcare systems? Why not go back to those chest CTs, identify people with very high CAC scores, also identify people with a CAC score of 0 in a recent scan, so that we can exclude those also from the trial. And based on this paradigm, we came up with this review about the topic that we believe that is being very informative in the design of trials in this space nowadays. And actually, we see that nowadays several trials like the Salius, Strength, the Clear Outcomes trial, Victorian One Prevent, and others are using this paradigm, and it's very reassuring to see giants in the field like Steven Nissen, like Deepak Bhatt, using in their trials CAC for dual enrichment of the trials. On the one hand, they use CAC to identify candidates at very high risk of ASCVD events. And on the other hand, now they're also using a CAC score of 0 to exclude participants who would be otherwise considered good candidates for inclusion in the trial. So my take-home message is, I would like to emphasize that CAC definitely can aid the allocation, the personalized allocation of any intervention in the primary prevention of ASCVD. That incidental CAC is an important finding because it's strongly associated with ASCVD events, and definitely something that you want to look for in your CT scans performed in your system and in your patients, regardless of whether they were done for this specific purpose or for other clinical indications. This is going to be really informative. Incidental CAC leads to enhanced preventive therapy use in primary prevention, statins, and most likely of other interventions when indicated. And finally, there's an increasing role of CAC in reaching primary prevention RCTs, and this is likely to become the new normal in the field. And most likely in the future, all ASCVD prevention trials in primary prevention will be using CAC to select the best patient population for the trial. So I wanted to thank you very much for your time. It's been a pleasure. I look forward to a question and answer discussion. Thank you so much.
Thank you very much. That was a great lecture. Very, very, very important data that you showed, and I'm sure everyone enjoyed it very much. So please put your questions in the Q&A, and we'll go through them, and we'll show the code for CME for all of you that want it. So I'll start with one question. I think it's very, very important what you're doing in your hospital about the referrals of the higher yield for those patients with CAC to the prevention clinics. In the practical aspect, how do you do that? You notify the primary physicians to make sure they're okay. You just empower the patients and you tell them, in a notification. How do you deal with these small things that make a huge difference?
Yes, thank you so much, Leandro. So yes, this is a hospital-wide strategy. We had tried to involve everybody that could be relevant in this process of referral of patients to our clinic. So first of all, we definitely involve the leadership of the hospital. They're very supportive of the strategy. Nowadays in Spain, there's a big focus on primary prevention, also in the hospitals, at the hospital level, and also in primary care. So definitely leadership involved, and then everybody in the cardiology department, they are seeing patients not only in the hospital, but also they go to the primary care centers in our area. They are seeing patients there every week. So whenever they are asked by the primary care physician about this finding from the chest CT reporting some calcification of the coronary arteries, or when they see this in a chest CT done for other purpose, they would just refer this patient automatically to the clinic. And also there's automated searches. We're using different tools to systematically detect those patients, which can be pretty intensive because especially for chest CT patients and patients, for example, from respiratory medicine, they can have a lot of other things that are important in terms of their prognosis. So maybe you don't want to start this kind of intervention in a patient who has COPD that is very severe or advanced cancer. So there's a process of detecting the right patients to be referred to this clinic. We try to focus maybe on patients who are younger than 75 years of age and who don't have other conditions that would shorten their life expectancy for the next 5 years, I would say. But it has been pretty busy. We started in October 2022. And so far, we've seen close to 300 patients. And yes, it's a pretty busy clinic, definitely.
Thank you very much. A great job. So we have a question from Karim. He says he put this question before. He didn't want to forget about it. He says, we're using the 10-year ACVD calculator in your slides. How do we integrate the new prevent calculator with the decision-making process? Is it interchangeably?
Well, great question. So we haven't had the time yet to test whether CAC could be useful in prevent. I think prevent is a great tool, even though it seems like the improvement in the area under the curve compared to pool cohort equation is actually pretty modest. So I would expect CAC to still be pretty helpful in those patients. And of course, in Europe, I'm working in Barcelona, so we are not using prevent here. We're using SCORE2. But I think there will be a lot of research in the coming months testing whether CAC improves or not prevent.
Thank you very much. We have a question from Mario Garcia, our chief. He asks, at what age is the power of zero really powerful? What do we do below or above that range?
Oh, well, this is definitely something that always comes up, and I think there was a lot of controversy also with the research in chest pain patients with CAC 0. I think in general, in younger people, you really don't want to make a big deal of a CAC score of 0 because most young people, they do have a CAC score of 0. I think in those ages, my focus would be on primordial prevention, on healthy lifestyles, and making sure that we minimize lifetime risk. I think in the middle age range, there's where this tool is going to be really informative. And actually, very young people usually would get estimated risk that is below 5% with the pool cohort equation, so you wouldn't have a reason to do a CAC scan there. And even though there's some literature showing that it can be useful when you find a very high CAC score in a younger individual, the problem is that you're going to have very few individuals with high CAC scores in the younger age range. So I would focus on the middle age range. And then in the older population, nowadays we have some really interesting data from ARIC, from BioImage and other cohorts. And what we're learning is that the percentiles are different for older people, and you don't want to I mean, you're not going to find that many CAC zeros, but maybe a CAC 50 in an 80-year-old person is actually pretty protective. So I think Matt Budoff tends to say, use the percentile in the extremes of age and use the absolute value between 50 and 70. And I think that would be the way to go.
Thank you very much. We have a question from Daniel Lorenzati that is on the same topic. It says, what do you think about the use of a more granular classification of CAC, incorporating the minimal 1 to 10 for guiding management, especially in young populations? It has shown to exponentially increase the risk in the Danish study of Mortensen.
Oh, yes, absolutely. I think in going back to the percentile thing, I think having a CAC score, let's say, of 20, 10 in a 35-year-old who for whatever reason gets the CAC scan done, it's a pretty important finding in such a young person, whereas in an elderly person, this wouldn't make any difference at all, or actually would be pretty protective. I think in younger individuals, that's the kind of young people that we bring into the clinic. So sometimes when we see a CAC score of 10 in the scan and the person is 42 years old, we definitely want to make an intervention in this person because the trajectory for this person is going to change quite a bit in the next 20 to 30 years. So yes, absolutely. Again, percentiles in younger people are very informative, and a CAC score of, I don't know, 10 would be a pretty high percentile in a young woman, especially, and most likely also in a young man as well. So yes, absolutely right. And always a big deal to find plaque in people who shouldn't have plaque, which is a 30 or 40-year-old person. Yeah.
Yeah, and in particular, I believe you can't, even that we're using CAC, you can't forget about comorbidities, you can't forget about age. That's very important, right? If you have a patient with FH and diabetes, you wouldn't stop the statin in these people, probably.
Oh, no, never. I think one of the biggest controversies in the field has been the misinterpretation that the power of zero thing could lead to not using something like statin in people who, for other reasons, they would be at high risk anyways, like people with diabetes, FH, etc. I think in those discussions, the focus of CAC and CAC zero was more about the other therapies that you might want to use in addition. But I think in those situations, using the statin does make a lot of sense for almost every patient with those characteristics. Yeah.
Okay, perfect. We have a question from our fellows. It comes back to the same question of when is it too young to use CAC? What stage where you would consider it first? And what about looking at plaque in other places, like in the carotids or iliofemoral, like the PESA study has shown?
Yes, I think those studies, PESA, SCAPIS, and others have shown that actually having some plaque at middle age is pretty common. So you want to always put those findings into context. First of all, it makes you realize that maybe you don't want to look for plaque in general in the general population because you're going to find a lot of minor findings that are going to be hard to interpret. But when you have that information and you put it into context, if the patient is really young and has some plaque, I definitely would try to be as aggressive as possible, at least with a very strong and intensive lifestyle intervention, which is going to be pretty good, reducing the risk of ASCVD, but also cancer and many other conditions that are going to be linked to an unhealthy lifestyle. In terms of looking for plaque in other areas, what we're seeing is that, well, first of all, we know from studies like MACE and others that coronary plaque burden is the most informative finding in terms of primary prevention and risk assessment, even better than carotid plaque. But sometimes we do have that information and we don't have the coronary plaque burden, so it can be also very informative. What we're doing in our clinic, sometimes in patients in whom we are not completely sure about the management, because maybe the CAC score is not so high, the patient is middle-aged, and we want more information, we might also check the carotid arteries. But usually they wouldn't change much the prior decision. I think when you know about the burden of coronary plaque, I think that's pretty informative already. And you also have the clinical risk score, like score 2 or whatever. I don't think we do have the evidence at this point to go and look for additional findings. But if you do have it in your system, because for whatever reason that patient underwent, I don't know, a full body scan or underwent other tests, why not check those? Because sometimes you find surprises in the abdominal scan and you might find plaque in the abdominal aorta, etc. So I think it's worth always trying to check those prior tests and then making a decision incorporating everything. But I wouldn't scan my patient and I wouldn't do all these tests to make the final decision, because usually patients are just willing to do whatever we recommend as specialists. And I think based on the coronary plaque burden alone, you can make a lot of final decisions or very informed decisions. So.
Thank you very much. We have a question from Jonathan Bradlow that he says, what about looking outside the heart? What about the aortic calcification? Does it make any difference on management and outcomes?
Well, same as before. I know. I think many of us have been interested from a researcher standpoint on the role of aortic calcifications. I think shows you that the patient has exposure to risk factors like especially high blood pressure and so on. I wouldn't do a scan specifically for that purpose, but if I do have the information, I have the scan, I would definitely check how the aorta looks, because if the patient has atherosclerosis in the coronary arteries and also has calcified plaques in the aorta, definitely this is a high-risk patient with a multi-vessel or multi-territory disease, and definitely I'm going to go for an LDL below 55 in that patient, not only below 70, but below 55.
Yeah, we've seen some data in our group that with patients with LDL over 190, if they have a calcium score of 0, but they have plaque in the aorta, the mortality goes up. So
absolutely,
I couldn't agree more.
I mean, I think we need to learn more about what is the right management specifically for those findings, whether we should be focusing on LDL, whether we should be focusing on blood pressure reduction. I think what you want to do is to focus on all risk factors and reduce the global risk. But most likely in those patients, blood pressure control seems to be pretty relevant. I don't know what's your experience, Leandro, in your patients.
Mm-hmm. Yeah, no, I couldn't agree more. So we have a question from Omar Said. He asks, what is the role or timing on repeating a CAC for those with CAC 0?
Well, there's a lot of interesting literature in that space. I don't have the chance in my system to repeat CAC scans because, as I was mentioning, for example, in Spain, the use of CAC in primary prevention is not that frequent or that easy. So if we have a CAC score 0 patient, we are usually not going to order another scan in a few years because that's not the way things work here. But it does make sense, maybe in the US, in specific healthcare systems, to maybe repeat the CAC scan at 3 to 5 years, especially if you're using the CAC 0 information to withhold therapies, that at some point it might make sense. And there's a lot of literature in that space from MESA and other cohorts assessing this repeat CAC scan process. On the other hand, if the patient has some CAC in the first scan, I wouldn't repeat the CAC scan to make additional decisions later. I would try to use the initial CAC scan to make all those decisions, whether the patient should be on a statin or not, whether the patient should be on aspirin or not, whether the patient should be treated more aggressively for blood pressure control or not. I think the initial CAC scan can be really informative. And why delay those interventions? Why not use that initial information to make all those decisions, right?
Do you think CCTA will be shown to be superior than CAC for progression or regression?
Well, CCTA is really promising. We have the SCAPIS data, Miami Heart Study data. I mean, in people with a CAC score of 0, it looks like in terms of CCTA, they really don't have a lot of high-risk plaque or a lot of risky findings on CCTA if the CAC score is 0. Of course, we're talking about asymptomatic people from the general population, middle age. But we definitely need to see the follow-up data from those studies to see whether it does make a difference or not. I think it's super exciting. And the cheaper it gets and the more available it gets, CCTA, I think is going to have a greater role in primary prevention. But if CAC 0, I don't know whether we're going to have a strong reason to do the full CT scan if the patient already has a CAC score 0 and not no indication for those therapies. But looking forward to those data. In a couple of years, I would expect those papers to be out.
Thank you very much. I agree. So from Aldo Scanone, he asks, do you see a future where CAC is used for all patients and not under a certain group? You touched base on this a little bit before, but do you think we'll reach that point where, and I'll push it a little bit more, where imaging will be used for decision in general?
Well, I used to work with Khurram Nasser, and he definitely was enthusiastic about this concept of why use any clinical risk score at all, given all the limitations, and why not use imaging. I think it's a really exciting paradigm. I think it does make a lot of sense from a precision medicine standpoint. But I think the biggest challenge, especially when I see it from a European standpoint, with a public healthcare system that has very limited resources and, for example, very limited access to CT scanning in clinical care, because it's really hard to use few machines in the hospital for so many indications. It's going to be really hard to have the data to support a generalized use of those tests. I think for now, given the context and the resources that we have, is going to remain something that we use for those specific patients who are, first of all, open to incorporating that information to the decision process, and second, in whom we are not sure what should be done, because maybe the patient already has very strong reasons like CKD or really high LDL cholesterol levels. So we don't need additional information. We just need to convince them about committing to the statin therapy or whatever. I think it's an ideal scenario, but I think it's really hard to implement.
Great. So thank you very much. I think we can end with that. Really, really enjoy your lecture, and hopefully we'll see you in the US soon.
Oh, thank you so much, Leandro. Great talk to you. Thank you so much. Bye-bye.
Take care. Bye-bye.
Thank you.